Hypothyroidism in pregnancy clinical evaluation. Hypothyroidism is common in pregnancy with an estimated prevalence of 2 to 3% and 0.3 to 0.5% for subclinical and overt hypothyroidism respectively. 8. Endemic iodine deficiency accounts for most hypothyroidism in pregnant women worldwide, while chronic autoimmune thyroiditis is the most common cause of hypothyroidism in iodine-sufficient parts of the world. 9-10. The presentation of hypothyroidism in pregnancy is not always classical and may sometimes be difficult to distinguish from the symptoms of normal pregnancy. A high index of suspicion is therefore required, especially in women at risk of thyroid disease, for example women with a personal or family history of thyroid disease, goitre, or coexisting primary autoimmune disorder like type 1 diabetes. Risks of hypothyroidism on fetal and maternal well-being. Hypothyroidism is diagnosed by noting a high TSH associated with a subnormal T4 concentration. Subclinical hypothyroidism, SCH, is present when the TSH is high but the T4 level is in the normal range but usually low normal. SCH is the commonest form of hypothyroidism in pregnancy and is usually due to progressive thyroid destruction due to autoimmune thyroid disease. Several studies, mostly retrospective, have shown an association between overt hypothyroidism and adverse fetal and obstetric outcomes, for example Glenower 1991. Maternal complications such as miscarriages, anemia in pregnancy, preeclampsia, abruptio placenta and postpartum hemorrhage can occur in pregnant women with overt hypothyroidism. Also, the offspring of these mothers can have complications such as premature birth, low birth weight and increased neonatal respiratory distress. Similar complications have been reported in mothers with subclinical hypothyroidism. A threefold risk of placental abruption and a twofold risk of preterm delivery were reported in mothers with subclinical hypothyroidism. Another study showed a higher prevalence of subclinical hypothyroidism in women with preterm delivery, before 32 weeks, compared to matched controls delivering at term. 16. An association with adverse obstetrics outcome has also been demonstrated in pregnant women with thyroid autoimmunity independent of thyroid function. Treatment of hypothyroidism reduces the risks of these adverse obstetric and fetal outcomes. A retrospective study of 150 pregnancies showed that treatment of hypothyroidism led to reduced rates of abortion and premature delivery. Also, a prospective intervention trial study showed that treatment of euthyroid antibody-positive pregnant women led to fewer rates of miscarriage than non-treated controls. It has long been known that cretinism, that is gross reduction in IQ, occurs in areas of severe iodine deficiency due to the fact that the mother is unable to make T4 for transport to the fetus, particularly in the first trimester. This neurointellectual impairment, on a more modest scale, has now been shown in an iodine-sufficient area, USA, where a study showed that the IQ scores of 7 9-year-old children, born to mothers with undiagnosed and untreated hypothyroidism in pregnancy, were 7 points lower than those of children of matched control women with normal thyroid function in pregnancy. Another study showed that persistent hypothyroxanemia at 12 weeks gestation was associated with an 8 to 10 point deficit in mental and motor function scores in infant offspring compared to children of mothers with normal thyroid function. Even maternal thyroid peroxidase antibodies were shown to be associated with impaired intellectual development in the offspring of mothers with normal thyroid function. Interestingly, it has been shown that it is only the maternal FT4 levels that are associated with child IQ and brain morphological outcomes, as opposed to maternal TSH levels.